The rate's between 50 and 140, and we're looking for things that matter. So ischemia, STEMIs, electrolyte abnormalities that can kill people as well. Things you got to know about 12 leads, you got to be able to calculate a rate. Obviously, the machine will show you one when they hook up to the patient, but you got to be able to confirm that. Sometimes if somebody's an AFib or having multiple PVCs, the rate's not correct. So a good way to get the pulse rate is put your hand on the patient's pulse, radial, femoral, carotid. But on the monitor, you got to have a way to kind of look at the paperwork and figure out the rate. And I use the 300, 150, 100 method to kind of do that. Intervals, you got to know these. PR intervals, useful for first-degree heart blocks, but more importantly, to recognize hyperkalemia. The QRS will determine if you have a bundle branch block, left or right, which kind of affect how you interpret if there's a STEMI or not. And the QT interval is very important because a long QT can make somebody going torsades, puts them at high risk for having VTAC arrest. So those things you got to be able to recognize and interpret, okay? So 12 leads, I think these pretty simple. This one, is it too fast, too slow, or okay-ish? I say the rate's okay-ish, right? It's not, I get concerned rates less than 50, all right? Now, if the patient's got a heart rate of 60 and they're diaphoretic and hypotensive, I'm concerned about that as well. But obviously, just routinely rates 50 to 140 are probably okay-ish. This rating is in the 70s, so it's okay. So the next thing I look at is I look for injury patterns. So I'm looking at leads 1, AVL, and 5 and 6 for ST elevation, which would be STEMIs, right? ST depression, T-wave inversion is concerning for ischemia, maybe some heart damage, but it's not a STEMI at this point. But those are the injury patterns you think about there for lateral. 1, AVL, and 5 and 6, those are your lateral leads. 2, 3, and AVF are your inferior leads, and you're looking for elevation or depression there as well. So every EKG that I look at the same way. I look at it, I check the rate out, then I'm looking for injury patterns. So I go lateral, then I look inferior. The next thing I do is I look for V1 through V4. ST elevation will be either a septal or anterior infarct, all right? But also in these leads, if you have ST depression and T-wave inversion, that's concerning for a posterior infarct, okay? So this V1 through V4 looks at the front of the heart. So elevation is a STEMI. If you got ST depression, the back of the heart is having really ST elevation, so that's a STEMI as well. All right, and it's not just T-wave inversion. You got to have that ST depression because that means there's ST elevation on the backside of the heart. Does that make sense? All right, my monster's about half gone, so I know I'm talking fast. If I need to slow down, do something on the chat box so I know it, okay? Sweet. The last place I look is lead AVR. We used to think that leads 1 in AVR, or AVR was only useful to see if the leads are on correctly. So if you're up in 1 and down in AVR, your leads are on correctly. In reality, ST elevation and lead AVR with ST depression in any other injury pattern, be it lateral, septal, anterior, inferior, is concerning for a left main disease. Either they're having a big stimular left main, or it's the 90-year-old who is now septic and hypotensive and is straining out that left main, and that AVR gets ST elevation. So very concerning. The uncool thing about this is most 12-lead monitors aren't going to pick up AVR elevation and call it a STEMI. So you're going to have to recognize that and pass it on to the receiving facility so that a doc looks at it pretty quick to see if that's somebody that needs to go to the cath lab or if somebody else needs just resuscitation to kind of get the heart out of that strain pattern, okay? This is just a little schematic kind of shows. So 1, AVL, and 5 and 6 is lateral to left circumflex. 2, 3, and AVF is inferior or the right main, and then V1 through V4 is the going down the right middle part of the heart, okay? And then AVR, you can see he's kind of coming off the aorta.
What does it mean if there's a cat on the 12 lead?
We'll talk about that later, okay? Yeah. I can't be perfect, okay? Get it perfect? That's not even funny. All right. First case, 38-year-old female. This is one from about a week ago. Recent cocaine use, has complaints of chest pain. She is short of breath. She's weak, nauseous for the past 3 hours. Initial vital signs by first responders was she was hypotensive of 88/60. Heart rate was slow at 32. She was breathing about 26 times a minute, and the SAT's running about 94, 95%. All right. So if you think about things we're going to do, what are we going to do for this chick initially? You guys got to talk. There's nobody else here. Yeah, right. So she's definitely symptomatic. She's going to need a 12 lead. She's got chest pain. She's bradycardic. Very concerning, right? So you think about three things that cause bradycardia. You think about ischemia, STEMIs, electrolyte problems, and then some kind of drug overdose, either intentional or unintentional, right? Beta blockers, calcium channel blockers. So I would say we got the vital signs. We're going to have hands on the patient. She's going to get on the defib pad, so we can make sure we got a good lead there. If we got to do anything with that, we're going to open the airway. She can get IV access. We also need to get a quick dextrose, a glucose, very important. If the glucose reads high, you start thinking maybe she's hyperkalemic because the fact that her glucose is high. And if you're in DKA, you get hyperkalemic. All right, so IV access, fluids. I would go ahead and give her some supplemental oxygen, but I would call it pre-oxygenation. She's not really hypoxic, but she is breathing fast and she's bradycardic. So a little supplemental O2, but you document it as pre-oxygenation before she arrests is reasonable to do for that, okay? There's good data that high flow O2 in the non-hypoxic patient for long-term is very bad, okay? But in the immediate first 15, 30 minutes of figuring out what's going on, it's reasonable to do, because if she goes into arrest with this, you just crank that nasal cannula up and initiate CPR, and you get some passive oxygenation, okay? So sweet, so 12 lead, it's a 12 lead class. This is our 12 lead right here. There should not be identifying data on this. If you see it, let us know and I'll take it off, and definitely don't share this stuff because these are real patients that we've de-identified. Is that the right word, de-identified? De-patient identified?
It's fine.
Okay, you know what I'm saying. All right, sweet. So too fast, too slow, or okay? Too slow, I agree with that. So rate is too slow. So as I'm looking at this, I'm intervening with the patient, IV access, fluids, okay? And I'm looking for injury patterns. Leads 1, AVL, and lateral. I got some, that leads 1 has got some artifact. Lateral ones 5 and 6, and AVL kind of flattened out, some T-wave inversions. 2, 3, and AVF, we got some T-wave ST, a little bit depression, but nothing super scary except for the rate. V1 through V4, no true ST elevation, but still the rate is uncomfortable. And the last thing I look at is lead AVR. And I'm doing this in a matter of a couple of seconds. So I'm not going to spend 10 minutes looking at this because the patient is unstable. But 12 lead, don't see an acute STEMI there, but definitely it's abnormal. So how do we treat this? We've already mentioned fluids, a little bit of O2. What else do we want to give this chick? This atropine, yeah. So pacing is good. What's the problem with pacing in the state of Alabama? It's Cat B, right? So atropine is great. Atropine is cheap. It's easy. There's a low risk. State product. Oh, there you go. My inappropriate humor. We'll move on. Thank you, somebody, for laughing. I know it was fake. So atropine's pretty good. State protocol says you start at 0.5. I think it's reasonable to give 1 milligram. If I give somebody 0.5 of atropine and they don't get better, I'm going to give them 1 milligram. If I give them 1 milligram and they don't get better, 2 milligrams is not going to help them. So atropine is quick, it's easy, there's a low risk to this drug, all right? It may not work, but it's not going to cause a bad outcome if it doesn't work. So atropine's pretty good. What's the next drug we can try? By state protocols, category A. I love this drug still, even though hospitals hate it. Comes in our bags, pre-mixed, dopamine, right? So dopamine's quick and easy, all right? The dose technically is 2 to 20 mics per kilo per minute. The way you do this is you need to know the dose. You need to know how to calculate a drip factor and count your drops. But in reality, the way that I'm going to do this is I'm going to spike the bag. I'm going to hang up the patient. I'm going to open up full, give it a few minutes to prime the tubing, okay? While I'm doing that, I'm maybe checking my AccuCheck. I'm getting the pacer pads on this lady. If I got a partner that are already on the phone with med control saying, hey, I got a patient who is symptomatic and bradycardic, not improving. I need orders for calcium and orders to pace. So that way you got it, okay? That takes a few minutes. Within the 3 to 4 minutes, if the dopamine has not kicked in and worked, then you're moving down the line with what you're going to do. If the dopamine works at that point, then you're going to calculate your drop rate. And I would start it at 10 mics per kilo per minute, which is right in the middle, 2 to 20, all right, and titrate to effect from that point. Does that make sense?
So what's the danger if the dosage is too high for the dopamine?
The danger is they would get super hypertensive and super tachycardic. I think the risk in a patient who is bradycardic is limited, okay? So we don't use dopamine for septic shock a lot of times now because people get tachycardic because of that. And we don't want somebody who's septic and hypotensive to have a heart rate of 140, 150. But dopamine increases heart rate and blood pressure. And in the symptomatic bradycardic patient, that's the ideal drug. Okay. Epi is a reasonable drug as well to use, an epi infusion, not epi push, but epi infusion. The problem with epi infusion is, one, you got to mix it. Two, you got to calculate the drip rate, and that's one you really can't just kind of prime like we did dopamine, because I've seen epi given IV and people going to VTAC, and that's poor form to go from heart rate of 30 to a pulses and a heart rate of 200, right? All right. You can treat it, but it's poor form, right? But dopamine is a relatively safe drug in a symptomatic bradycardic patient. Yes, sir.
We use Epi because we don't have dopamine on our truck.
Are they premixed?
No, it's 1 milligram and 250 mL.
Okay, yeah. So that's the problem.
So would you rather us use the Epi or just go ahead and go to pacing?
So
like, which would be safer?
So for epi infusion, you got a call for that?
No, it's Cat A.
It's Cat A? I didn't know that. I have to look that one up.
We have like from our medical director, it's Cat A.
Yeah. Technically, you can't alter the protocols without a variance from the state.
It is. It's from the state.
Really? Okay. All right. So if it's Cat A, then if you can do it, that's fine. If you know the drug dosage, you know how to calculate the drip, epi is a reasonable thing to do. Okay.
Couple of quick points.
Yeah.
So in the state of Alabama, we're required now to carry the dial flow IV sets.
Okay.
Nobody uses them.
Okay.
So use them. We got them on the trucks. Use
Okay.
them. Don't give a dopamine, and certainly not an epinephrine drip, without at least using a micro drip set.
Right. So you
All
can
of those
calculate the
10 drop or 15 drop sets. And that's
right.
very dangerous.
Right. So for me in my practice, I can alter because I don't have to follow the protocol. Right. So I'm going to open that up, prime the tubing. I think it's reasonable for you guys to prime that tube and get the fluids going in, but you're not going to run that without calculating the drop factor or the rate for a long time. Does that make sense? You're not going to give them 200 cc's of the 500 bag of dopamine because that's way too much. Make sense? Sweet. All right. Thank you for almost smiling.
So another quick question.
Yeah.
The traditional teaching and initial EMS education, all the textbooks talk about getting into alpha effects at high dopamine rates.
Right.
How that can cause internal organ ischemia and all that kind of jazz.
Right.
You see a big risk there?
No, I do not. I do not. Now, again, if you give too much, it can, but it's not going to happen. If you're priming the line, you're watching it, and within a minute or so, you're slowing that down to the rate that needs to be done at 10 mics per kilo and adjusting that. Okay. The bigger risk to the patient at this point is bradycardia that is not responsive to atropine and they're hypotensive. Okay. And the bigger risk is it's going to take you a minute by rule to call to get orders to pace somebody. Okay. I think pacing should be A. We're not there yet. Other thing I mentioned when you call med control is talk about calcium. Remember, if somebody's hyperkalemic, calcium will help correct that, and that will make their heart rate go up. Signs of hyperkalemia we learned in the textbook is, peak T waves. Peak T waves are great, but they don't affect the conduction system. What gets you with hyperkalemia is that QRS gets real wide and the PR interval gets real wide. So you see people that look like they're in heart block or almost a sine wave or a new junctional bradycardia, and they're really hyperkalemic. You give them some calcium, that QRS narrows and works pretty good for you. So calcium is category B, except in cardiac arrest with hyperkalemia or concerns for hyperkalemia. So that's one that I would ask for when you call med control as well. Get orders for calcium and get orders for pacing. Calcium also, the way these drugs, epi, dopamine, in a nutshell, how they work is they increase calcium inside the cardiac cell and it increases heart rate and blood pressure. So if you give them a boatload of calcium, in theory, it increases intracellular calcium and they work better. All right. So calcium is good. Then obviously the most important thing that you're going to be doing next is you can start pacing that person. Okay. 3 things to think about with bradycardia: drugs, electrolytes, ischemia. We talk about heart blocks. Those are important to recognize. But in the setting of a symptomatic patient with a heart rate of 30, the treatment's the same. So even if they had a 30-year heart block, I'm still going to give atropine first because there's no risk to it, potential benefit. All right. And also sometimes it's hard to pick up complete heart blocks, okay, on the monitor when you're stressed out and you only got a few minutes to manage these people. So blocks really don't matter until you get them stabilized. All right. If atropine works, it probably wasn't a complete heart block. Same thing with dopamine. Pacing is going to be your answer there, but you'll get to that if you do that same algorithm every time.
So there's still a persistent teaching that you should never give atropine to a 3rd-degree block.
There's a, right.
What's the rationale?
There's a
behind that?
theoretical risk by blocking the AV node, you can just slow the heart rate down even more. It's theoretical. If it happens, what's the next thing you're going to do? Pace, yeah, or dopamine, epi, and pace. So the other problem with that is that sometimes it's tough to determine, is it a high-grade heart block, secondary type 2? Is it a third-degree heart block? There are some secondary heart blocks that are type 1 that when the rates get less than 40, they look like complete heart blocks, and they get better with atropine. So it's a relative risk. And if you're going to heart rate of 30, can't get much worse with already hypotensive. That makes sense? Yes, sir.
I've heard that atropine being an anticholinergic agent.
Yeah.
If they've had a heart transplant.
It's not going to work. It won't work. Yeah. Yeah. So if they got a big zipper and they say I'm a heart transplant, it's not going to work, right? Is it going to hurt them though? No. Not going to hurt them, but it's not going to work either. So routine management, I'd recommend fluids, atropine, dopamine, epi if you got it and you know how to use it, is an infusion, not a push, and then calcium and pacing, okay? And when you're calling in, you can even, if you're a one ALS, got one medic and an advanced, or a medic and a basic, all right, you can have somebody else call in med control and give the report. Hey, 40-year-old patient, hypotensive, heart rate in 30s, not responding to atropine. I need orders for calcium and pace. And a reasonable docs can say, yeah, go ahead, see you when you get here. All right, so that way the medic keeps working. All right, this one, too fast, too slow, or okay. Well, hang on. This is that. So same patient. This is the 12 lead from the hospital. So it's still way too slow. All right, but now we'll look what we got. We got T-wave inversions in 1 and AVL and lateral. Those are more pronounced. But look at 2-3 and AVF. What do we have there? We got elevation. Yeah. So now we got this person. So when you think about the progression of a STEMI, what happens is the heart gets poor perfusion, EKG changes, or you get flip T waves, ST depression, and then if it keeps going on, that T wave goes back up, the T wave goes upright, and then you get ST elevation. So this is a STEMI in progress right here. So we got 2-3 and AVF. So now this is a STEMI. So now we know the cause of her bradycardia. It probably wasn't hyperkalemia or drugs. She just have ischemia, right? And we know it's in the RCA area, so it's probably knocked out the SA node as well. All right. So obviously, this patient at this point, if they're still mentating, they got to have an aspirin. In the hospital, we're going to start antiplatelet drugs such as heparin or Brilinta, something like that. And they need one of two things: either they need to go to the cath lab and get a balloon and a stent, or they need lytics on them, thrombolytics. Okay. Obviously, if the blood pressure is still low, they're not mentating, we got to pace them as well. So serial EKGs make a big difference. That was the first one. And I'm going too fast. Sorry, Chief. And then that's the second one. So you see there is a difference there. And remember, we've talked about aspirin until you're probably sick of hearing about it, but aspirin basically blocks the receptors on platelets, so it makes these clots not get any bigger. Aspirin, one of the most important things we can do for these people. Aspirin works on the platelets. We give heparin. It blocks a different receptor. Then if we were to give a thrombolytic, it would go in and break that clot up and flush it downstream. In Europe, they do a lot of thrombolytics early on, then go to the cath lab. The reason in America, a couple of reasons. Well, one reason in America that we do cath lab is because the risk of reinfarction in the next few days, the risk of a bad outcome and not having to get a repeat event is better if you stent people versus just give a thrombolytic. So a lot of times we'll do rescue lytics. So if I'm working in a small community outside of Birmingham that doesn't have a cardiologist and I have a STEMI, I'm going to give them TPA or TNK, a thrombolytic, fly them or drive them to a hospital that has a cardiologist, and then they will get their stent. Some states, pre-hospital providers are giving thrombolytics in the field. They're giving a drug called Retivase. They recognize the STEMI. They do the STEMI checklist. If there are no risk or absolute contraindications, they will lyse that, hopefully get some relief of pain, good perfusion to the heart. Then they go to the cardiologist and they get a stent done. So this checklist is in the protocols. I would like to see these filled out and given to the docs at the hospital. In reality, I know a lot of places don't carry the paper ones. If nothing else, this needs to be a verbal report to the physician receiving the patient that you talked about the STEMI checklist. Because if they go into cardiac arrest once they get to me, and I don't know this data, I can't license them. If I know this data, I can say, okay, they're having a STEMI, went into VFib, did not get better from a defibrillation. I'm going to give them a thrombolytic, open that vessel up, okay, and hopefully salvage them to get them to the cath lab. When you think about heart attacks, there are two types, okay? There are STEMIs, which we learning to pick up here better. EKG shows ST elevation, you get myocardial muscle loss, they get dysrhythmias, they get bradycardic, they get VTAC, they get VFib. High morbidity, mortality, people die from this, very bad. We treat with a left heart cath emergently. We can do lytics to bridge, but left heart cath is the way to go. The blood test troponin, which is an enzyme the heart releases if you have a heart attack, sometimes is not up with the STEMI because it takes a few hours for that blood test to be positive, right? With the NSTEMI, that is a STEMI that does not have EKG changes. EKG does not show ST elevation. The problem with these kind of injuries is they get myocardial muscle loss, they get dysrhythmias, they can get bradycardic, they get VTAC, get VFib, the high morbidity, mortality, and we treat them with a left heart cath urgently or emergently. In short words, STEMIs, NSTEMIs are bad for people. They should all get a heart cath. STEMIs need one now. NSTEMIs need one probably in the next 24 to 36 hours. NSTEMIs are diagnosed by the symptoms and by a blood test called a troponin, okay? So those are the two big differences. So you can see a lot more of these non-STEMI patients going to the cath lab in the future because outcomes are pretty bad there too.
So
All right.
is it fair to say that if the patient's having a heart attack,
Right.
myocardial infarction, and we're not seeing ST elevation on the 12 lead, so it's an NSTEMI.
Right.
Is it fair to say that the infarcted tissue is not all the way through the wall of the heart, and on a STEMI, the infarction is all the way through the wall of the heart?
That's a good way to say it, yes, sir. But I've seen people have NSTEMIs, and then all of a sudden they switch over into a heart rate of 20 and having a STEMI. So
Right.
yeah. So
from a pragmatic point of view,
Right.
what you're saying is when we see the 12 lead EKG changes with the elevation and it's a STEMI,
right.
they got to go to the cath lab right now.
Time
so
doesn't matter.
It's important for us to get them to a hospital that has a cath lab available.
Correct.
And for an NSTEMI, we're going to schedule it.
Right. Usually for NSTEMIs, they get it done a day or so later. And unless that blood test we're talking about, that troponin, is going up crazy. So if it's like tripling every couple hours, we know that it's ongoing ischemia. We need to cath them now before they do STEMI out. Okay.
Is it also fair to say that even in a city that has as many medical facilities as Birmingham, there's never enough available cath lab space? Or it's sometimes not enough.
At some point, there's not. That's why we have the STEMI system. That's why if you have a patient with chest pain or concerns for ACS, nausea, vomiting, shortness of breath, you do the 12 lead on the scene before you get in the back of the truck and you're rolling around and you transmit that. And if it's a STEMI, we got to find where to go because every hospital may have somebody on the cath lab table. Okay? Sweet. So let's do a quick review of left and right bundles, and then we'll take a quick break and move on to the next thing. So remember, conduction system, SA node to AV node, down the bundles. A right bundle branch block, you'll see there's a block in the right bundle, and I guess you got my mouse if it works, but it may not be able to point, versus the left, right? Just some diagnostic criteria. Right bundle branch blocks, you're going to have a big R wave in V1 going up, a positive R wave. With left bundles, you're going to have a downward deflection, big Q wave as well. We won't talk much about vectors. That makes people drool. I'll mention it here in a second. For left bundles, that's probably the most important one to recognize. The QRS for either bundle has to be greater than 120. For left bundles, I look for a Q wave in V1 and no Q wave in lead AVL. And that's what I look for. There are a lot of ways to determine this. For a quick, easy diagnostic way to do it that gets the majority of them, that's what you look for. Wide QRS, Q wave in 1, no Q in AVL. All right. Causes of left bundle branch blocks is usually the fact that that left bundle, left heart ventricle is enlarged for some reason. Chronic hypertension, maybe previous heart disease, okay, things like that. So you know that you have a diseased muscle, and it stretches I just lost it, the conduction system in the heart, and it slows it down. All right, so this one, too fast, too slow, or okay. I'd say it's an okay rate. I'm looking for injury patterns. 1, AVL and lateral. I got T-wave inversion, maybe the depression in 5 and 6. 2, 3, and AVF look reasonable. V1 through V4, I got some ST elevation, right? A couple of millimeters, and 1, 2, 3 with T-wave inversion, ST depression in 4. So it's a concerning EKG. I go to AVR, that looks reasonable, all right? So now I start looking at my intervals, all right? I see P waves. My QRS is pretty wide. It's greater than 120. So now I'm going to go say, I got a wide QRS. Is this a bundle branch block? Probably is. So I go look at V1. I got a big Q wave. I go down and look at AVL. I have no Q wave, so this is a left bundle. So I really can't call this a STEMI at this point in the game because it's a left bundle, because I'm going to have these ST changes septal and anteriorly. So this is a left bundle branch block. It's an abnormal EKG, but it does not really meet STEMI criteria. In the past, years ago, if somebody came in with chest pain, was diaphoretic, and we saw this EKG, would say, all right, maybe it's a STEMI, maybe it's not. We're going to treat them like it's a STEMI because they got a left bundle, and we don't know if that stuff is real or not real, that ST elevation. Now we got something called Scarbosa's criteria, right? All right, and this basically gives us a way to determine if we think this left bundle is an acute issue and there's a STEMI going on. The main things you want to look for is concordance. So T-wave and QRS should be opposite. Discord is good. Concordance is bad. So ST elevation with concordance, QRS and T-wave in the same direction, very bad. Concerning for a STEMI, they go to the cath lab. All right. Discordance, discordance more than one big box is also concerning. It's not always as effective as looking at the concordance, but discord that's more than 5 millimeters or one big box is concerning as well. So let's look at this one now. So rate's okay. I'm looking at injury patterns. We kind of talk about that. So now we know our QRS is wide. It's 163. All right. I got Q wave in 1, no Q in AVL. So this is a left bundle branch block. All right. So now I'm going to say, is this ST change for V1 through V4, is it concerning or not? I got discord in V2 and 3, and it's not more than 5 millimeters. I see no concordant ST elevation, so this is not a concerning EKG. It does not meet Scarbosa criteria, so I feel pretty comfortable with this patient. Now, if they're diaphoretic, blood pressure's low, they look like dirt, I'm still concerned for the patient, right? Patient exam makes a difference, but this EKG is not super scary, all right? Questions from internet land or anywhere else? All right, let's look at this one. Rate's okay, start looking at injury patterns. I'm up in 3, where's lead off? Yeah, 2, 3 in AVF, all right? V1 through V4, got some ST depression, AVR looks good. And then if I look at leads 1, AVL and lateral, I'm up laterally as well. So concerning for a STEMI, but my QRS is kind of wide. So I got to say, is this a bundle branch block? I got a Q wave in 1, no Q in AVL. So this is a left bundle, and I can apply Scarbosa then. So 2, 3 AVF. I got concordant ST elevation in 3. That's very, in 2, very concerning. Also have it laterally in V5 and V6. So this is very concerning for a STEMI. Machine doesn't pick it up because it's a left bundle, and it's tough for the machine to interpret left bundles, but you can. That makes me very uncomfortable. That patient will get thrombolytics or go to the cath lab. All right? Sweet. So those are the left bundles. Here's another left bundle, I think. Rate's okay. Got a Q in 1, no Q in AVL. All right? Actually, that's the first one I showed you earlier, I do believe. So that's a left bundle, no Scarbosa. You also see they got AFib. So folks with left bundles who have heart disease may also have underlying atrial disease as well. They got a sick heart at baseline. This one, the rate is okay. I look at 1 in AVL and lateral. I got some T-wave inversion, ST depression laterally. 2-3 in AVF, same thing. I go to V1 through V4, and I'm up some in V1. I go to AVR, I got ST elevation in AVR, and I got depression we already kind of talked about laterally. This is concerning for a left main disease, but my QRS is 160. So I got to figure out is a left bundle or a right bundle, all right? I got a Q wave in AVL, I got a positive R in V1. This is a right bundle. So right bundles, you don't need scarbosa, all right? So this is a very concerning EKG. I would call this a STEMI. I'm up in AVR, I'm up in V1 too with some lateral and inferior ST depression. So I'd call that a STEMI. It's a right bundle showing a STEMI. This one, the rate's okay. My QRS is a little bit wide. Is there somebody killing a cat?
Could somebody please tell Boss the cat to be quiet?
So we're up in V1, a little bit of a Q in AVL. So this is a right bundle branch block. But if you look at V2 and V3 and V4 and V1, you got ST depression, T-wave inversion. So you would think this would be a STEMI, a posterior MI. Right bundles will mess with you when it comes to this. This is pretty common for a right bundle. Do I have the vectors on there? Yeah, so with the right bundle, what you're going to see sometimes is ST depression, septal and anterior, because of the fact that conduction is slow through that right bundle. You're going to see those sloop T waves and ST depression. So I would not call this a STEMI. It's a right bundle with a posterior injury pattern, but not a STEMI because it's a right bundle. The biggest risk with right bundles is you think about you get a right bundle because the right ventricle is swollen or diseased. In the acute setting, the main cause of that is somebody has acute pulmonary embolism. So they're hypoxic, they passed out, pleuritic chest pain, and you got a right bundle, you think they got a PE until proven otherwise. The best way to learn these EKGs, guys, is do a lot of them. Life in the Fast Lane is a good web page. Wave Maven is fine. You can go to YouTube, their Google channels, all that stuff. You want to find some place that shows you a 12 lead, makes you interpret it, and then you look for the answer. The more you see, the better you're going to get. All right. So this one's just another left bundle. Another left bundle, no scarbosa. You see the down in V1, Q wave in V1, no Q wave in AVL. You can tell the different morphologies. This one's not as bad as the previous ones because you don't have that big discord in V6. All right, so this is a chick who passed out, had bystander CPR, probably about 10 minutes, got a couple of shocks because she was in VFib and woke up, was confused, and couldn't tell us a lot. So the rates, too fast, too slow, are okay. I said the rate is fine. Injury patterns, I got some T-wave inversions in AVL, a little bit laterally. 2-3 in AVF, not super scary. V1 through V4 looks reasonable. And then AVR is notched, but it's not a STEMI there, okay? When I look at my intervals, I got PRs, but my QRS is a little bit wide, so I got to think, is there a bundle branch block? So I look at V1, I got a big R wave. I look at AVR, okay? A little bit of a Q, not much there, but so this is a right bundle. So with the right bundle we talked about, you should see ST depression in V1 through V4 of some sort, and we don't see it. So this right bundle makes me concerned for a STEMI because it's a right bundle and we're pretty upright V1 through V4 with no ST depression where it should be down. Okay, so this is very concerning for somebody who has a right bundle branch block having a posterior event or a septal anterior event. Either way, though, she just had a VFib arrest. She needs to see a cardiologist and go to the cath lab. She went to the cath lab. She had an LAD occlusion, got a stent, doing pretty good right now. Questions?
Yeah, so we've been actually getting Ross back on some medical cardiac arrest patients.
Yes.
And being thoughtful enough to get a 12 lead before we leave the scene.
Right.
And wow, they're all crazy.
Yes.
So the active CPR is going to change the 12 lead.
Right.
So regardless of that, and really regardless of what we see in the 12 lead, and it's good for documentation to get the 12 lead, I think.
Right.
But regardless, those patients really need to go where there's an available cath lab.
I would say yes.
After cardiac arrest.
I would say yes. If you get ROSC, the main cause of VTAC, VFib arrest is STEMI. So they need to go. Now, some people have bad heart disease and just can have dysrhythmias. But most people, VTAC, VFib, should go to the cath lab. And the only way you know which one needs to go is when you get to the cath lab and you do the test. So I agree. And you're right, post-arrest, you're going to have changes in that EKG. That heart is reperfusing, get dysrhythmias, all kind of things. The good thing,
plus trauma,
plus
CPR.
Right. But the good thing is, I hate to say it this way, but you may get lucky and it be a blatant STEMI post-arrest, then there's no doubt they go to the cath lab. Some places like to cath, some places don't. In some parts of the nation, we're setting up resuscitation centers. So post-cardiac arrest goes to the resuscitation center where they can get cath, or they can get cardiac bypass, ECMO, and things like that. It someday will be that way here as well.
Would a good transitional step towards that idea be to change the STEMI system requirements to include post-cardiac arrest patients with ROSC?
I don't think we'll get buy-in from cardiology at that point right now. I don't think we will. Yeah. But I think they should go to the cath lab. So this one I just want to kind of talk about. This one, again, identifiers are marked off. If you see something that's there that shouldn't be there, let me know so I can change it. Chest pain, short of breath, rates okay. Injury patterns, 1, AVL and lateral looks fine. 2, 3 and AVF looks good. V1 through V4, we got T-wave inversion. I think that's why this was put in the system. But remember, for posterior infarcts, you got to have ST depression as well, not just T-wave inversion. All right, and then AVR looks pretty reasonable. So nothing super scary here. Obviously, if you have an EKG that you're concerned about, you think it's a STEMI and it doesn't say STEMI, call TCC. They will direct you and get that EKG to the receiving facility to look at for confirmation. I'd rather you overcall than undercall. But this one, that T-wave inversion, you got to have ST depression as well on those V1 through V4 to call it a posterior. Inappropriate humor. Painful, that's right. I think that was Chief Ward in 1978 as the patient. All right, we're running low on time. We'll kind of bypass some of these. Oh, I do want to do this one. Hang on. I showed this one last time as well. So this is a left bundle. All right, QRS is wide. We're down to V1, no AVL. So I got ST elevation V1 through V4. Not super scary. We looked at that a few minutes ago. This one's a little bit tricky. There's a joke in there somewhere if you know histology. I guess that's histology. Is that what that is? Sure, we'll say it's histology. I don't know. Rate's okay, but we're up in V1, V2, V3. So we're thinking, oh, it's a bundle branch block. All right, so not a STEMI. However, if you look at the QRS is 92. It's not greater than 120. All right, I got a little bit of a Q-wave and AVL. You can maybe say it's not there. All right, I got downward deflection of V1, but I don't have a wide QRS. So it's really not a left bundle. So therefore, this is a STEMI. That patient needs to go to the cath lab. So remember, to have a left bundle, you got to have a wide QRS defined by a QRS greater than 120. Okay. Don't get burned, because that machine sometimes has trouble picking up V1 through V4 and recognizing STEMIs. This one I've talked about every time. Short version, remember, our protocols say chest pain, suspected ACS. Forget the chest pain, think suspected ACS, because chest pain is part of that. Nausea, vomiting, diaphoresis, shortness of breath in an older person is concerning for coronary occlusion. Get a 12 lead. This guy did it. He was working in the Birmingham area, got a 12 lead. You look at V2, V3, we got ST depression, T-wave inversion. That is a posterior STEMI, different than that one I showed a few minutes ago. Biggest cause of death with these things is VFib arrest. Medic was astute, put him in the system, even though the patient was really complaining of urinary problems and nausea and demented. Put the pads on her to the appropriate care. She went to VFib arrest, got one shock, and came back. So it's a good call, astute clinician. Also remember, your 12 leads don't always pick up STEMIs. So at some point in the game, you're going to have to be able to do that. You're going to have to be able to read your own 12 leads, make a difference when you can. I know 90% of what we do in the pre-hospital and the ER does not seem emergent, but there is that population that we do help out. Don't miss the chance to do the cool stuff. So changes that are coming. In the hospital, we studied door to EKG times. We've got 10 minutes to get an EKG on anybody with ACS symptoms. That's coming to the pre-hospital world. We're looking at not door to balloon time, but first patient contact to balloon time now in a lot of parts of the nation. So I say that when you get on scene, you want to get your 12 lead done within 10 minutes of seeing the patient and get that transmitted if it's a STEMI or you're concerned about it, all right? Because we're going to track those numbers back, especially with CARES in the future. Makes a big difference, and it's going to help us out because it's going to make us be able to do more things, maybe move into doing pre-hospital lytics, things like that in the future, if we can show we can do this kind of work, okay?
I knew you were a David Bowie fan.
All right, questions, comments, statements within reason. Let's take a break, and we'll let Dr. Payne come in and knock out some stuff.
Hey, everybody, we're going to take a short break. If you have a question, type it in the chat feature on Teams, and I'll relay it to the docs. We're going to take just a few minutes. When you come back, we'll have the quiz game set up, play for some really great prizes today. I'm not even sure what we have. I think we have like a $2 gift card to Sonic or something, but it'll be great, whatever it is.
To Sonic. It's funny. Sorry. I'm still live before I start telling inappropriate jokes. Yeah. You know why Americans don't like knock-knock jokes?
What's that?
Because they like to let freedom ring. Ding dong. Never mind.
Hey, everybody. Instead of doing the break right now, Dr. Payne's actually going to share some information with us on seizures. We'll do the break then with the game, and then Dr. Payne will have a lecture on toxicology for us. Please remember to send an email to Alabama EMS challenge@gmail.com. You'll get a reply email with a link to an attendance form. The password for today's class is toxic, since we're talking about toxicology and since Dr. Ferguson's humor is toxic.
All right. Can you hear me, everybody? Good? Okay, I'm Dr. Taylor Payne. I'm one of the second year ER residents. I did a lecture about a month ago. So today we'll be talking about seizures, take a break and do the quiz game, and then we'll end up with some toxicology. So seizures, there's a lot of different types of seizures. Basically what a seizure is any kind of abnormal electrical activity of the brain that causes the generalized muscle contractions that you see. The problems with seizures is if it doesn't stop, it can basically cause brain damage due to the ongoing metabolic demand. You can think of it as the brain running a sprint, and the brain and metabolic features of the brain just can't keep up after the seizure for so long, and you end up with hypoxic brain injury from it. There's two different types of seizures. There's generalized, which is when you actually have a loss of consciousness. Tonic-clonic, which is what usually people think of when you just say seizure. It's the entire body has rhythmic movements. And you get the tonic phase, which is the rigidity, and then the clonic, which is the kind of jerking back and forth. There's a couple of different types of other generalized seizures. There's what's called a absence. It's spelled absence, but it's French. It's absence. This usually happens in peds, and it's described as staring spells, and you won't have the rhythmic jerking. Not as important for EMS, but just to know that's out there. The other big class of seizures is a focal seizure. There's no loss of consciousness in these patients. You'll see this in a lot in the peds world. Basically, you can have a rhythmic jerking of just one side of the body or even one extremity of the body. Sometimes it's in the hands or just the legs, and you'll see rhythmic jerking. However, the patient's fully awake and aware of what's going on. And basically, these are all treated the same. Simple versus complex is not as helpful. It depends on how long the seizure's been ongoing, basically. So there's many different causes of seizures. They're primary neurologic, which can be a structural deficit of the brain or just some type of tissue in the brain that creates abnormal electrical activity. Epilepsy just means people that have chronic seizures that's not from a structural cause. That's all epilepsy means. But you can have several different things that actually cause seizures. You can have, sorry, I should remind me I wasn't doing my slides. So there's neurologic. There's trauma, sometimes from hemorrhagic strokes, TBI. You can have infection, meningitis, or any kind of brain abscesses can cause seizures. You can have different ingestions, toxic ingestions, as we'll talk about later. Hypoglycemia is a very important cause of seizures. You can also have hyponatremia, in which the sodium levels get too low in the blood that can cause seizure. Also eclampsia, which is specifically in pregnant women. That can is basically a disorder of the placenta that will lead to hypertension and cause seizures as well, and it's an important cause. So the important historical elements of seizure is how long the seizure's been ongoing is basically one of the biggest important things to ascertain when you get on scene. Is it still going on when you get there? The vast majority of seizures will stop within 2 to 3 minutes. So it's very important to, if the seizure's still ongoing, to see how long it's been going. The longer it goes past 3 or 4 minutes, the more chance that it will be harder to break. And that's just kind of generalized for all seizures. The longer it goes, the harder it is to break. Classical thing you see, postictal state after a seizure, the patient will be very sleepy, groggy, however, should respond to stimulus. It usually improves over time, and that's a strong sign that they actually did have a seizure. Important things to ask is the patient had any history of seizures in the past? Are they on any meds? What type of meds are they on? Has there been any history of recent trauma? Some other important historical factors that can lead you of whether this was a seizure or not is, was there any tongue biting, any fecal or urinary incontinence will give you a higher level suspicion that the patient actually had a seizure. Also ask if the patient's pregnant or if there's any possibility of the patient being pregnant in the appropriate setting. So this is a very important slide. So you might get called out on a seizure, and it might be very hard to differentiate initially if the patient's had a syncopal and had some myoclonic jerks versus actual seizure. So you might get called out on a seizure call and actually be either just syncope or the patient is having ongoing arrhythmia. Because basically, if you have a fatal arrhythmia like VTAC or VFib, the patient's brain is going to be hypoperfused because of that. They're going to lose consciousness, and they can actually have myoclonic jerks for a few minutes, basically a seizure, because of the hypoperfusion from the arrhythmia. So it's always super important to check pulses on these patients when the seizure stops, to get an EKG to make sure they're not having ongoing dysrhythmia that's just masquerading as a seizure.
So a couple of things there, Dr. Payne. So we've actually had several calls in the last month here at Centerpoint Fire that were dispatched as seizure, but were actually cardiac arrest when our crews arrived. Bystanders described seizure-like activity.
Right.
Any seizure activity that we encounter with a patient that we're treating who's, say, 40 or above, should we be concerned about cardiac dysrhythmia? Is that a leading cause, you think, especially if there's no previous history of seizures?
Yeah. I mean, I wouldn't say it's a leading cause, but I think it's something you need to be worried about in any age group, really, not just older people. If you have a younger guy, and I guess what I'm saying is that you need to be checking a pulse and getting EKG as soon as possible after the seizure finishes. Because if these people are actually having dysrhythmias, the seizure is not going to last long because the brain is just not going to have any perfusion at all. But it's just extremely important to think about it. Probably the biggest thing also to be concerned about if you have an older person that has a new onset seizure, no history of seizures, is an intracranial hemorrhage. That's basically intracranial hemorrhage until proven otherwise if you had an older person that has a new onset seizure without any history of seizures.
So I think I might be skipping ahead a little bit, but from our point of view in the pre-hospital setting for seizure management, would you say that it's reasonable for us? When do you want us to treat seizures pharmacologically? Obviously, if they're actively seizing, we should give a benzo.
Yeah.
What about those patients who are postictal upon our arrival? Bystanders report seizure activity, but we didn't actually see any. How long do you wait there? Do you wait till they seize again before you give the benzo?
Some people have different thoughts on this, and Dr. Ferg might have different thoughts. Some people say go ahead and give a benzo up front just to prevent that next seizure. But a lot of people say that, well, most of these seizures will break on their own and won't need benzodiazepines at all. They might just need a load of whatever their chronic seizure medication is. So I don't know. I would probably personally say if they're not actively seizing, don't give a benzodiazepine to muddy the picture and just to let that be decided at the hospital unless they have another seizure. Dr. Ferg might have other thoughts on that.
Yeah, I think that's reasonable as well. I think the main point for us, just from a practical point of view, is if we get there and there's any suspicion that they've had seizure activity and they're postictal when we get there, is to get an IV while they're not seizing.
Yeah, exactly.
So we can give it IV if we need to.
Yeah, and I'll talk a little bit later about drugs, but this access on these people is incredibly difficult. So that's going to be, when you can get an IV, go ahead and get it before than afterwards. So pediatric febrile seizures, they're super common, mostly benign. Usually it's just one episode. It's associated with a fever in a kid, otherwise healthy. These are non-focal seizures. So if you have a focal seizure in a kid that's febrile, that's more concerning. Usually it's associated with acute elevation in temperature and not necessarily absolute temperature, as some people may think. It's familial or runs in families. And basically, most of these seizures will be a one-time seizure and will resolve on their own. But if they do have ongoing seizure activity, you just treat it as any other seizures.
Yeah, the one comment I'll make there is I've actually seen some literature that talks about temperature change being the cause for febrile seizures, like you said, but not only rise, but rapid decline. And so this can be very confusing for our crews. They arrive on the scene with a small child who is postictal, and the patient doesn't feel feverish.
Mhm.
And a lot of times the parents just giving them acetaminophen or ibuprofen.
Yeah.
Have you seen that much? A rapid break of fever causing a febrile seizure?
I haven't seen it personally, but I can see where it makes sense because they've found that it is more familial and something in the genes of the kids is what causes, and it's that change in temperature that will actually cause the seizure. I haven't seen that personally, but I think you're going to treat it either way. If there's a history of a seizure and the kid's had a seizure, you're going to send them to the hospital and they can.
And as a side note, just because somebody has a febrile seizure as a child, that doesn't really change their likelihood of having epilepsy or seizure disorder as an adult.
Correct.
Those two things are unrelated.
Correct. That's unrelated. Yep, that's correct. Yeah, that's what a lot of parents are really concerned about, and they ask about that a lot. But that's correct. So immediate seizure management, of course, it's what y'all are all great at. ABCs, maintaining airway, finger stick glucose, like we've already talked about. The teaching is to turn the patient on the side, so there's not a lot of aspiration, if at all possible. If the patient had a history of trauma, it's always it's good to remember your C-spine precautions. Suction if needed. If there's airway compromise, the patient's actively vomiting. And just like I said before, it's super important to check a pulse immediately when the seizure stops, get an EKG afterwards, and point of care glucose. Those are always super important right after the seizure stops. So like we talked about before, if the seizure fails to terminate, if the patient's actively seizing in front of you, these are all Cat A drugs, I believe, Versed, lorazepam. Versed can be given IM or I intranasally. Sorry, I don't know why the slides keep going forward like that. Whatever access is available, these people are really hard to get access on. So if you have intranasal, that's great. If you can do IM is great too, especially for Versed. It's always important to think if this patient is pregnant or there's a possibility of pregnancy at all, you can give magnesium. You can give that IM as well if you have a hard time getting access. So status epilepticus. Basically, seizure activity that lasts for more than 30 minutes is the actual definition, or if a patient does not return to baseline before the next seizure activity. So basically, if somebody's in a postictal state and they have not returned to their full neurologic baseline and then have another seizure, that's still considered status epilepticus. It's very damaging to the brain just because of the reasons we've already talked about, that the metabolic demand is so high, these brains will become hypoxic from that and just damage very quickly. Basically, what happens in the ED when we get these patients, we have a very algorithmic process of different drugs we escalate to. But eventually, these patients, if they don't break, they'll just need intubation and sedation with propofol is usually what we do. We can also load them in the ED with phenobarbital. You'll treat them the same way in the field. Just give benzos, get on the phone with the medical director, see if you need to get more benzos than what the initial dosing calls for. There's been a couple new studies come out recently that actually show that we were probably underdosing benzodiazepines for seizures, at least initially. So, if you're given the first couple rounds, I think it'd be wise to get on the phone with the doc, see if you need to give more, if you can, if you're able to.
So we occasionally get calls to especially kids or even some adults who have a lot of seizures, chronically constant seizures. And a lot of times the families will wait to call us until the patient's been seizing for an extended period of time, 30 minutes, an hour, that sort of thing. Is it reasonable to start at a higher dose of benzo with those types of patients, or at least call medical control and talk about it?
Yeah, I would call and talk about it. I think that's totally fine. The problem is those type of patients that have some kind of underlying genetic abnormality or have an epilepsy seizure disorder, it's probably going to be hard to break with just benzos anyway. So they're going to need, to be taken to the hospital and have their chronic epilepsy drugs up titrated or something like that. So yeah, I think it'd be fine to go ahead and call, see if you can get a higher dose. But it just letting you know, it's probably going to be hard to break anyway with those type of patients. I mean, that's why they're having them anyway all the time, is because it's just so hard to manage.
Do you think that hypoxia is a big contributing factor to lasting damage from status epilepticus?
Yeah, I think so. Like I said before, it's more of the there's just no metabolic substrates anymore. because the brain is constantly being activated, and they run through all the glucose, all the other glutamate, all the other substrates in the brain, which will eventually lead to hypoxia just because the cells in the brain are not getting any fuel. And basically, it's just like your muscle dying, basically.
So it's reasonable for us to concentrate on preventing hypoxia.
Yep.
To do more than one D-stick if they're in status that we can't break.
Yeah.
And if they're hypoglycemic, to give them.
Right, and it's not as much as like the total body hypoglycemia. It's going to be the hypoglycemia within the brain itself. So even if you have a normal like blood glucose reading, it's the brain that's actually not getting the substrate. And I don't know if you can fix that with just getting systemic glucose. It's going to be just stopping the seizure however you need to.
Right. So it's more important to get the seizure under control.
That's correct. That's what I would say. Yeah.
Right.
Yeah, that's correct.
And preventing hypoxia.
Correct.
Obviously.
Yeah, all the other stuff. And try to prevent aspiration because that's going to lead to hypoxia after the seizure and things like that. Yeah. So just go over a couple drugs that we use commonly in seizures. All these are benzodiazepines. Sorry, guys. All these are benzodiazepines. They work on the GABA receptors in the brain. You can think of the GABA receptors just the brakes for the brain. You have two different receptors. You have a receptor that stimulates the brain and a receptor that slows down the brain. GABA is the receptor that slows down the brain. MDMA and glutamate is what speeds up the brain, and that's what kind of gets out of whack in seizures. But all these drugs are CNS depressants. They can cause respiratory depression. That's the big thing that we always want to look out for when we're giving benzodiazepines. So we need to monitor these patients. We need to have a BVM ready to go just in case they start getting hypoxic or bradypneic while you're giving these meds. So the dosage for adult is 1 to 2 milligrams IV slow. And of course, Cat B, you got to be on the line, but pediatric is 0.1 mg per kg IV slow. There's not a rectal form of this like there are with some of the other medications that we're talking about. So Versed, also benzodiazepine. The dosage is similar. You can give this IM as well. There's been a couple different studies for pre-hospital for Versed, and it performs just as well IM for breaking seizures as lorazepam IV. So if you can't have access at all, this is a great drug for IM, to give IM. Dosages are similar. Adults 2 milligrams IV, IM, or intranasally. Pediatric is 0.1 mg per kg, IM or IV. But it's also a category B. There's a little more potential for respiratory depression with Versed versus other benzodiazepines, so it's just something you have to watch out for. So Valium, also a benzo, similar things, potential for respiratory depression, just like all the other ones. The big thing to remember for this one is the dosages are different, so don't get these confused. It's a higher dose. Adult is 5 to 10 milligrams IV. You can also give this per rectum. I'm not sure if y'all have access to this where y'all work or not, but you can give it per rectum if you can't get any other access. And PEDS is similar. You can give per rectum as well, 0.1 milligram per kilogram IV push for Valium. That's all I had for seizures. Any specific questions on seizures?
Is midazolam, will it absorb through the pararectal route for adults?
I'm not sure. I didn't see that indication. For, do you know? Versed for rectal? Yeah. I mean, if you can give something, if you give something IM, why not give it IM? Especially with the studies that show that Versed IM is just as good for breaking seizures in the pre-hospital setting. So.
More expensive than Versed, so it's easier to get Versed now. There's no reason we can't do it nasal or IM.
All right, good deal. Yep. Another question?
So with kids, IM is typically not preferable because they don't have as much muscle mass. So I had a 3-year-old who was having a seizure for 30 plus minutes.
Yeah.
But she had a trach. If you give it intranasally, is it still going to work the same if they have a cuff trach?
Yes.
Yeah.
Yeah,
because
absorb right in the nose and stuff, so that works fine. And if you had to go IM, you can still go IM. You just don't let you defy
And you can also do IO if somebody's actively seizing, if you're able to.
If you see some 30 minutes, you can have.
You can do IO and give it that way.
Right, net control, IO, and then give it IO. Okay.
Good question. Thank you. All right. Everybody take just a real quick break, about a minute, and we'll come back and play the game. Got some sweet prize today. Just got notified. You're going to have a Magellan tumbler, $20 cash, and a Sonic gift card. Only one prize today, not second place. Second place is just first loser anyway. So get ready for the game. Okay, everybody get ready to play the quiz game. Go to www.kahoot.it. Enter your nickname, enter the PIN number that you see on your screen. You'll use your phone as the answer device. You use your phone as the answer device. Prize today is a Magellan tumbler, $20 cash, and a gift card of unspecified amount to Sonic. It's unspecified because I don't know what it is. I'm going to give everybody about 1 more minute to join. So if you haven't joined, go ahead and get signed up. www.kahoot.it. Enter the PIN number you see on your screen, the 161991, and a nickname. And remember, people see your nickname. I appreciate the diagnosis, Spuckets. Thank you for that. All right, got 16 players. We're about to start. Everybody get ready. You got to pay attention. Remember, right answers get points. Faster answers get more points than slow answers. So be as fast as you can. You'll use your phone as the answer device. Here we go. Which of the following is true about left bundle branch blocks? Which of the following is true? Left bundle branch blocks always prevent 12-lead interpretation. QRS is always narrow. Sometimes the 12-lead can indicate STEMI, or the R wave is always positive. Up in V1. Which one of those is true? Yeah, the right answer is sometimes a 12-lead can indicate a STEMI even if there is a left bundle branch block. You can use Barbosa criteria and figure that out. The R wave for a left bundle branch block is always negative. All right. BA in the lead. Diagnosis buckets. Close second. Based on this 12 lead, you should suspect posterior STEMI, anterior septal STEMI, lateral STEMI, inferior STEMI. The ST elevation is so huge that even you old people in the room should be able to see it. It's pretty significant and obvious, just saying. Oh my God. All right, yeah, so that was anterior septal STEMI. Unfortunately, most of you picked inferior. That was not the case whatsoever. We saw a big, huge ST elevation in V1 through V4, which would indicate anterior septal STEMI. All right. BA has shamefully fallen to third. Balls is coming up strong in second, with Leah and Mom in the lead. Which of the following dysrhythmias is a significant risk factor for stroke? Atrial fib, sinus arrhythmia, right or left bundle branch, or SVT, supraventricular tachycardia. Which one? And all but one person got it right. AFib, if you just watch TV and see commercials, you should have got this one right. AFib is super high risk factor for stroke, particularly new onset AFib. Is that correct, Doc? Yeah. New onset. Lee and Mom maintains her lead. It appears that BA has fallen off the board. Balls Buddies is in a close second, or as we refer to it, the first loser position. Based on this 12 lead, what should you suspect? Should you see a left bundle branch block, a right bundle branch block, fascicular block, or is this a pacer rhythm? Questions get a little tougher as we go along. So if you remember the criteria for the bundle branch blocks, would be very helpful in answering this question. So this one is a left bundle branch block. Most everybody got that right. Very good. So we had the YQRS. You notice that V1 was negative, be a left bundle branch block. Lee and Mom maintain their lead. I think Balls Buddies have actually fallen behind a little bit. BA still remains off of the board, shamefully. When should you intentionally lower the blood pressure of a stroke patient in the pre-hospital setting? When should we lower the blood pressure of a stroke patient? If the systolic blood pressure is above 160, if the patient complains of a headache, if the diastolic blood pressure is above 100, or we should never intentionally lower the blood pressure of a stroke patient pre-hospital. Which of these is true? And never. Yeah. We don't intentionally lower the blood pressure of a stroke patient pre-hospital. That can actually harm the patient pretty significantly. They may control the blood pressure in hospital, but we should not do it pre-hospital. El Diablo takes the lead in a strong move, overtaking both Lee and Mom, and Ball's buddies are still in first loser position. Shake and bake. Question 6 and 9. According to Alabama EMS protocols, what's an appropriate pre-hospital stroke intervention? 0.4 milligrams of nitroglycerin sublingual, 500 milliliter bolus of normal saline, 4 milligrams per kilogram of ketamine IM, or 324 milligrams of aspirin by mouth. Which of these is an approved EMS intervention for stroke? Yeah, 500 milliliters of bolus of normal saline. 2 of you said aspirin. Aspirin could be helpful. Turns out it also chokes people who are having a stroke in the pre-hospital setting, and there's no great advantage of giving it to them pre-hospital versus in the hospital for stroke. There is an advantage giving it pre-hospital for MI. And the 2 of you who said that you should give them nitroglycerin, shame on you. Shame on you. Go back to school. You're dropping their blood pressure. We don't do that. El Diablo, strong move, taking the lead. Ball's buddies, still first losers. What is a common rash that forms a honey crust? If you remember from last lecture, a honey-colored crust. It's a very common skin rash. Is it ringworm, impetigo, psoriasis, or rosacea? Hey, it's impetigo. Absolutely nobody paid attention. Yeah, so I'll share that with Dr. During that you learned absolutely nothing last time. All right, let's see. El Diablo pulling away. Seizure making a run. Ball's buddies have been shamefully distracted. Seizure. Yeah, seizure, not seizure. Yeah, a little spell check goes a long way. This serious condition can be caused by antibiotics and sometimes seizure medication and forms a blistering rash. It's life-threatening. Are we talking about varicella, measles, Stevens-Johnson syndrome, or hand and foot disease? It's usually a reaction to medication. All right, very good. 10 of you got it right. Stevens-Johnson syndrome. Dr. During spent quite a bit of time on that last time. Thank you for getting that one right. El Diablo, looking strong. Lee and Mom, making a late comeback. This is the last question. What's the pediatric dose for ondansetron for a 66-pound pediatric patient? Zofran, how much Zofran should we give a 66-pound kid? Should we give them 30 milligrams, 4 milligrams, 3 milligrams, or 6.6 milligrams? All right, the correct answer is 3 milligrams, 0.1 milligram per kilogram, up to 4 milligrams according to our protocols. So 3 milligrams would be correct. And only 2 of you got that right, indicating we need to do protocol class once again. All right. El Diablo, you are the winner. You got the sweet tumbler with the $20 cash and the unspecified amount Sonic gift card. You can send me an email to wward@centerpointfire.com, identify yourself proudly, and claim your gift. thanks everybody for playing. Give me just a second to set it up, and we'll continue with Dr. Payne's lecture on toxicology.
We good? Yes.
Awesome. Yep, we're good.
We're good? Awesome. All right, guys, I'm going to talk a little bit about toxicology. So toxicology is just a huge topic. Basically any drug can be toxic at certain dosages. What I tried to pick out was maybe some of the more common ones you'll see, and also what's most important in the pre-hospital setting that you can make a acute intervention on right away that can really help these patients. So we'll go ahead and get started. These are the topics we'll cover: opioids, TCAs, calcium channel and beta blockers, cyanide, and carbon monoxide are going to be the big topics that we're going to cover today. So opioids, as y'all know, there's a huge epidemic right now ongoing. There's a lot of prescriptions given out for pain control in the late 90s, and that's what some people now thought of as what has kind of started the opioid epidemic. And now that we're starting to cut back on some of the prescriptions we're giving, those people that were initially dependent and abusing prescription drugs are now having to go to other street alternatives. Here are some of the names of common opioids: heroin, hydrocodone or Lortab, also called Norco now, morphine, oxycodone or Percocet, codeine. You'll see in a lot of cough and cold medications, hydromorphone, which is also called Dilaudid, and fentanyl, used a lot in the hospital, and also fentanyl is now being laced with some heroin products to make them more stronger, so they don't have, the drug dealers don't have to sell as much. The usual presentation for opioid overdose, I'm sure a lot of y'all know: depressed mental status, decreased respiratory rate, you'll have decreased bowel sounds, and miotic or very small pinpoint pupils. Respiratory depression is the main killer of this drug. It's not going to be the mental depression. It's not going to cause any changes really in hemodynamics. It's going to be the respiratory compromise that is going to end up killing these patients. Just wanted to briefly say there's a lot of different mimics to opioid overdose. So if you come across a young individual that you think may have overdosed, it's always good to keep in mind other things that it could be. Just don't automatically assume it's an overdose. Sepsis can cause altered mental status, can cause decreased blood pressure. Hypoglycemia can cause the same thing. Also, one of the interesting ones, a specific type of intracranial hemorrhage called a pontine hemorrhage. The pons is located in part of the brainstem, and it can actually cause a miotic or pinpoint pupils as well. So if you see this in elderly, decreased mental status, decreased respiratory rate, super tiny pupils, don't automatically think it's an overdose. It could be a patient having a stroke. So initial management, a lot of people like to jump to Narcan, but airway support is almost is really more important than even giving the Narcan. If you can ventilate the person, if you can do that quickly, that's important while you get the drugs and everything else set up for support of the patient overdosed. Jaw thrust is a great maneuver for these patients. When I was first taught about jaw thrust, I was kind of underwhelmed with it, but actually seeing it work out in the field, it's very vital. It can really open up somebody's airway that's not breathing. So it's a quick maneuver that you can do that's super helpful. So of course the treatment for opioids is Narcan. You give it IN now. It's a new way of giving it over the last 5 or 6 years or so. A lot of the police departments are now carrying it. Also IV, that we've had around for a long time. The usual dose that's taught is 2 milligrams. So the key with Narcan is you're basically wanting to correct the respiratory issues, okay? So our goal is not to get their mental status to return to baseline, okay? Because if we do that, if we give them enough Narcan to do that, then we could actually precipitate withdrawals. The patient's going to get agitated, and you might cause more problems than you have. So the key with giving Narcan is you're titrating it basically to improve the respiratory rate, to get them breathing on their own again, okay? So actually in the ER, when we give it, we actually use really small dosages kind of back to back and titrate to the respiratory rate that we want. We even start with like 0.04 milligrams. So what I would probably suggest out in the field is 0.2 to 0.5 starting. Of course, if somebody's in, acute apnea, you can go ahead and give a larger dose, that's fine. But in somebody that's just maybe breathing 6 to 8 times a minute, you can start with a lower dose, 0.5, and titrate up to the dose that you want, just so you don't have that risk of giving them too much and sending them into withdrawals and combative, and then you're having a patient fighting you all the way to the hospital. Does that make sense? So yeah, that's really it for opioids. We'll talk about TCAs. So TCAs was a common medication given for depression back in the 80s, 70s, and 80s. It's not used as much now for depression. It's sometimes used for depression that's hard to manage with other medications, but it is commonly given now in lower doses, but it's commonly given now for some type of migraine management. So you might see patients with this a lot. As you'll see, a lot of these drugs end in triptyline, as you see on the left, amitriptyline, nortriptyline. Also, you'll see ipramine is the suffix on some of these drugs as well. These are extremely dangerous in overdose. Okay, these will cause any ER doc to kind of start sweating when they hear about a TCA overdose coming in. And the reason is these patients can acutely decline very rapidly. They can be looking great and then all of a sudden acutely decline. This overdose presents in multiple different ways. They can have mental status changes. They can be tachycardic. They can be hypotensive. This drug is what we call a dirty drug. It acts on a lot of different receptors, so it can cause a lot of different things, most notably tachycardia and hypotension. The main receptor that we fear is the sodium channel receptor that it affects with the cardiac activity, and that will basically send these patients into VTAC arrest, basically. They'll basically develop VTAC and arrest with this. So the main thing we look at for this is getting an EKG up front. If the QRS is wider than 100 milliseconds, then the standard is a Cat B, but is to give sodium bicarb at 1 milliequivalent per kilogram. So in one vial of bicarb, it's going to be 50 milliequivalent. So usually for a normal Alabama patient, you're going to be given 2 amps of bicarb. The bicarb helps in 2 different mechanisms. It will make the patient less acidotic, which will take some of the medication off the receptors in the heart, and also it'll give a sodium load that will help some of the sodium channel effects of the TCAs as well. So that's really the most important intervention that you can do pre-hospital for these patients. And basically everything else is supportive care, even when they get to the ED. If they seize, we'll treat the seizures with normal treatment, benzodiazepines. But really the thing we have to watch out for is that QRS, because you'll basically see it widen, and they'll go into VTAC and arrest. And then once they arrest, they'll become more acidotic, and it's just a circle that is hard to get out of at that point.
So a couple of points on the tricyclics. So we used to see a ton of these, 20 years ago. Mm-hmm. Went away for a while. But we're actually seeing a resurgence. People are being prescribed TCAs for chronic pain management, which I don't understand the connection there. Mm-hmm. But just to make everybody aware that they're back.
Yeah.
We had a pretty serious overdose a few months ago here in the fire district with unresponsiveness, tachycardia, and wide QRS. We did treat with sodium bicarb. We didn't have enough. So speak a little bit about how much sodium bicarb it takes to effectively treat these patients.
Yeah, it's going to take a lot. And it's really, you're trying to prevent the acidemia that's going to send them into further VTAC. So yeah, you might need large doses. Like when we get to the hospital, we might have to start these people on a bicarb drip. So you're going to be giving a lot of bicarb to these patients. And even at that point, if the patient's already seizing, they might be so acidotic, it's going to be hard to correct with even bicarb. And yeah, so like chronic pain, migraine headaches is starting to be some of the more common indications you'll see now. It's at a lot less dose than it was initially back 20, 30 years ago when they were using it for depression. But still, if somebody takes a whole bottle full of these, you still get enough dose to cause symptomatology. So yeah, you'll see it for chronic pain and things like that.
So it seems with this last one that I'm referring to,
Mm-hmm.
it was actually a fairly gradual onset with that patient
Mhm.
symptoms.
Mm-hmm.
She was alert and oriented on the scene.
Mm-hmm.
20 minutes later was altered with the QRS starting to get wide.
Mm-hmm.
20 minutes after that, she was unresponsive.
Mm-hmm.
It seems like in years past, we would see a much more rapid onset. Is there a new formulation? Is it time released, or is that just that specific?
As far as I know, no. The ones I've seen in the emergency department, they've been, fairly alert, talking to you. Now, the initial symptoms that it causes are because of its anticholinergic properties. It'll cause basically an anticholinergic delirium. They'll kind of be talking out of their head, things like that. But they'll be alert. But the ones I've seen in the emergency department can go downhill very quickly. They'll become super tachycardic and then all super altered. And then basically you have to intubate them and give them the bicarb. So I'm not sure if there's a different dosage or something that might cause the more gradual onset. Yeah. Okay, calcium channel blockers and beta blockers, I kind of group these together because their presentations are going to be similar. And as y'all probably know, a lot of the beta blockers end in LOL, propranolol. You'll see metoprolol probably most commonly. You'll see labetalol given a lot in the hospital setting. Propranolol is also you'll see as prescriptions. Of course, what we're looking at for these is the cardiac effects are going to be very significant. You'll see these a lot of different ways in different settings, not just intentional overdoses. You can get accidental overdoses in peds, accidentally getting into their adult and their parents' medications, things like that. Also, I've seen a couple of these overdoses where you have a patient that's maybe has some CKD and they get some infection. For some reason, their kidney function goes down. And they will be taking their same level of beta blocker, and that beta blocker will actually just build up over time, and they'll be toxic because of that. So there's a couple different ways you can get toxicity from this, not just intentional overdose. The cardiac effects are, of course, most significant. You'll see bradycardia, hypotension, and this can be fairly refractory to any therapy you do. So management for these are EKG, get IV fluids as necessary. You might have to pace these patients, although if they're truly in a beta blocker or calcium channel blocker overdose, pacing probably won't be as helpful for these patients, but it's something to try if they're bradycardic and hypotensive. You can also on the severe spectrum see ultra mental status, but it won't be a super defining feature of this type of overdose. The treatment of beta blocker, calcium channel blocker overdose, like I said, IV fluids. You can give glucagon for beta blocker overdose, calcium chloride for calcium channel overdose. All these are Cat B drugs, but the glucagon you can give 1 milligram IV or IM, and calcium chloride is 1 gram, 10 cc's of a 10% solution. I'm not sure how y'all have it in the pre-hospital setting, but that's the usual dose for giving that. The calcium is basically just to give back. If you have a calcium channel blocker, give back more calcium to try to help the contractility of the heart. That's the idea behind it. The idea behind glucagon is you're actually going through a different pathway besides the beta receptors in the body to provide further substrates for the heart to contract better. So that's the idea behind glucagon. In the hospital, we'll start these patients on epinephrine drips. They might need 2 or 3 pressors if it's a severe overdose. There's a couple different special drugs that we're using now for this in the hospital. High dose insulin is something else we're doing for these, but these patients can be fairly refractory to therapy. So the most important thing is just to get them to the hospital quickly. Any specific questions on calcium and beta blocker?
Yeah, really from our point of view, we're not going to know, right, unless
No.
we have a very specific history on that.
Right.
And the other part of that is you're not going to know at the hospital
Mhm.
unless we get the very
Right.
specific history on the scene.
Right.
So collecting medications and gathering information on the scene becomes very important for these.
Yeah, so that's super important, you know, with any kind of overdose potential or a history of overdose. If you can get the medication and bring them in, that's super helpful for us. Or if you know what it is and can't bring it in, if you can just write them down the approximate or guessed dosages of the pills that they were taking. Any kind of information like that is helpful for us. Yeah, but in these patients, we often don't know. We often don't even know if it's an overdose, but if the picture fits, we'll treat it as it is. And I would say in the pre-hospital field, you're not going to know beta blocker or calcium channel blocker, so just give both glucagon and calcium for these patients. I mean, you got to be category B and talking to the doc anyway, but if I was on the other line, I would probably just say give both.
Yeah, talk a little bit about how dangerous these drugs are for the pediatric patient population, the beta blockers and calcium channel blockers.
So these can be very dangerous, especially in the pediatric population. We've seen as little as 1 to 2 pills can cause significant effects if they accidentally get into these from their parents' medications. So we often are very cautious when they come into the hospital, even if they're asymptomatic. We watch these guys for a long time, just because a lot of the calcium channel blockers are more extended release, so it can be a little while before we see symptomatology from it. So it can be they can look very well initially, but can be deceiving.
Yeah, a lot of the textbooks refer to both beta blockers and calcium channel blockers as one pill killers for small children.
Yeah, for sure. Yeah, that's why we're super conservative about watching these kids, even if they look fine. Yeah. Okay, cyanide. So cyanide toxicity. Cyanide is one of the most rapidly fatal poisons known to man. Usually in movies, you'll see it like with spies taking a cyanide pill. That's usually not what you're going to see in real life. You're going to see the most common exposure to cyanide is going to be from domestic fires in industrialized countries. The cyanide is actually a byproduct of various fabrics and plastics. If they combust, you can get a cyanide byproduct of that, and that's what we usually see from these exposures. The presentation is pretty dramatic. It's going to be basically hemodynamic compromise and cardiac arrest. You'll see a drastic, quick decline in somebody, and probably with these type of overdoses, the person's already going to be in cardiac arrest or near cardiac arrest when you get to these patients, just because it's so rapidly fatal. I think it's important to think about this in any house fire victim that is peri-arrest or close to cardiac arrest, to go ahead and just treat, in my opinion, just because you don't know, and it could just be they're cardiac arresting from hypoxia, but you don't know, right? So the treatment, cyanokit, hydroxycobalamin. There's a couple of older kits that have some sulfide agents that they used to use, but the first go-to drug now is hydroxycobalamin. It basically reacts with cyanide to form cyanocobalamin, which is actually B12. So it reacts in the body and creates a super safe vitamin. That's how it works. The dosage, 5 grams over 15 minutes. You might have to redose this. Of course, it's all it's Cat B, right? I'm trying to remember. Ferg, do you remember? Yeah. But,
I just asked in the chat to everybody participating online if anybody actually carries cyanokit.
Yeah.
We do not. I've
Okay.
never worked for an agency that does.
Mm-hmm.
So there's a shelf life issue
Okay,
and a
gotcha.
cost issue. One thing I've often wondered is I've always seen that dosage over 15 minutes.
Yeah.
Are we going to do that during cardiac arrest?
Yeah. So probably not.
So probably not.
Yeah.
What's your feelings on is it a amyl nitrite as an adjunct treatment?
Yeah, so that's what I was kind of talking about is some of the older medications. Those are fine. There's a couple of contraindications, but if somebody's peri-arresting, you can throw those out the window. They're going to need it. But yeah, the 5 grams over 15 minutes is more for somebody that's not acutely arresting, somebody that's pressure 60s over 40s that can get it in quickly, but not somebody that's arresting.
Right. So there's been some evidence, not necessarily strong to meet enough scientific criteria, but there's been some evidence over the decades that a lot of structure fire cardiac arrest, particularly of firefighters, is actually due to cyanide poisoning when it was previously believed to be cardiac in etiology.
Mm-hmm.
Have you seen any of those studies? Do you think there's a strong reason for us to carry cyano kit?
Yeah, see, and I don't know the answer to that. That's the question is, are these people dying from hypoxia, smoke inhalation? Are they dying from carbon monoxide poisoning? We'll talk about in a minute. It's a common thing with these, or is it from cyanide? It's probably, honestly, in all comers, it's probably not the biggest player in it, I would say, but nobody really knows the answer unless you do autopsies and postmortem.
I know one thing that's pretty consistent in the fire service in Alabama is rescues are fairly rare from structure fires, and when they happen, the victims almost never survive.
Right.
Even when the victim isn't unresponsive when they exit the structure, they still almost always end up dying. And I'm wondering how much of a role cyanide plays in that.
Yeah, and I don't think we have a good answer for that right now. I don't think we have data to say either way. But I think it would be hard to get data anyway, just because there's multiple factors that could be causing these patients ultimately to die. So.
Yeah. So looking at the protocol here, it looks like cyano kit is category A. They say not indicated in pediatrics. So category A, if indicated.
There you go. So that's cyanide. And of course, like other ingestions, or any other exposures like this, it's always important to get the patient out of the source. I forgot to mention that, but that's kind of common sense stuff. So carbon monoxide toxicity, this will be the last one we talk about. It's very, very common, especially in winter months. You see it. Carbon monoxide is a byproduct of impartial combustion of any materials, basically, but it's not a full combustion that converts to O2. Converts to carbon monoxide. We see it a lot in winter months. It's odorless, tasteless, colorless, as y'all know. The presentation can be subtle sometimes. It could be just headache, confusion, altered mental status. And also remember your oxygen saturation probe, unless you have the dual oxygenation probes now that can detect carboxyhemoglobin, is going to show 100% because it's going to be reading it as the same. So the way the pulse ox works is it basically can, with infrared, look at the wavelengths, and the wavelengths for carboxyhemoglobin and oxyhemoglobin are very similar. So unless you have a specific probe that can tell those wavelengths apart, it's going to read it as the same. So you might have somebody it says they're satting 100%, and they actually might be significantly carbon monoxide toxic.
So most people listening to this lecture have the rainbow sensors with either Physio-Control or Zoll, and I think both of those manufacturers have the capability that when it gets over 10% SPCO, it sounds alarm and switches from SpO2 to SPCO.
Okay.
So that's another reason to use the pulse ox on the monitor and not a separate fingertip sensor. There is a problem with maintenance and keeping up with the sensors. It's very expensive, and I've been fighting that battle for a long time, but that's one issue.
Right. Yeah, so basically how we ultimately diagnose this in the ER is we'll get a blood gas, and it'll show us our actual level of carboxyhemoglobin. So I think if you're suspecting this, if there's a history of either somebody's in a house fire or they had a kerosene heater and they're presenting with headache, altered mental status, things like that, I think it's appropriate to go ahead and treat it as carbon monoxide, even if you don't have the capability of seeing what the carboxyhemoglobin levels are in the field. So the treatment for this is, of course, get them out of the setting that's providing them carbon monoxide, whether if it's a suicide attempt or they're in a garage, as the classic presentation. Just get them out of that as quickly as possible. And then oxygen, and more oxygen is the treatment. Basically slap a non-rebreather on these patients, 100% oxygen all the way to the hospital. And that's mostly the treatment for these. Even when they get to the ER, we'll keep them on 100% oxygen. There's some data for hyperbaric oxygen therapy. It has been shown to prevent some of the chronic neurological conditions that can happen after in kind of the more long-term setting after these patients have had a severe exposure to carbon monoxide. So that's kind of the indications right now. If their initial carboxyhemoglobin level is at a certain point, then we'll go ahead and take them to hyperbaric chamber. Of course, to be treated in the hyperbaric chamber, they have to be stable enough to be in there and not need intubating and be also altered that they can actually handle it. So it's kind of a two-edged sword there. But basically, you're just trying to provide enough oxygen that offsets the carbon monoxide that's attracted to the hemoglobin.
So we do see carbon monoxide toxicity from time to time. I've seen it in my career several times. It's mostly been associated with house fires and people using portable heaters inside during the winter, like the kerosene torpedo type construction heaters.
Right.
And I've been to a couple of suicide attempts that involve carbon monoxide. So there's been a kind of a waxing and waning movement in the fire service to clip portable CO detectors to our jump bags. So when we go into a house, if there's elevated levels of sounds, I think that's a discussion we have going on in chat right now. I think Hoover's doing this. I know at one time I think Trussville was doing this. I think Trussville actually discovered a CO-rich environment that was not known to anybody by doing that. It's the only time I've heard of it happen. Any thoughts on that?
No, I mean, I think that's great. So is that basically when they're going in the house fire, that's like the air they're breathing in, or is that if they have a mask on, right, they're not going to be?
No, they're using it really for EMS calls.
So just EMS, like generalized calls, like
sound an alarm if you go into a house and there's elevated levels of carbon monoxide.
Yeah, I think that's fine. I mean, you're seeing a lot of people are going to the smoke detectors now that are both carbon monoxide and smoke detectors. Probably in the future they'll be both combined for everything you buy.
Yeah, Trussville Fire just indicated on chat that they do, in fact, have CO monitors clipped to their EMS bag. So that's something we've looked at here. I haven't pulled the trigger on it, trying to decide how much value there is to it. For those agencies listening, if you have those CO monitors, I'd be interested to know if they've ever gone off and alerted you to elevated CO.
And then what happens after that? Yeah.
So the other point there is if you're working for a fire service or if you're an EMS agency standing by in a structure fire, it's important to do firefighter rehab that includes SPCO, which means a rainbow capable sensor, fingertip sensor.
Right.
And also we've seen over the years that a lot of times guys that work for multiple fire departments, which is true for most of our firefighters here at Centerpoint, can have consecutive days of firefighting and kind of build up a CO level that becomes dangerous over the course of 2 or 3 days. I don't know if there's any literature on that or not, but we've seen instances of that anecdotally here.
Yeah.
And then James Robinson from Springville says a couple of cases from Springville in which he wrote this long word that he knows I can't pronounce. Carboxyhemoglobin alarm from the Zoll X during the exam of an unrelated complaint led to discovery. So that's good.
Yeah. And like I said, a lot of these symptoms are going to be very nonspecific: headaches, malaise, not feeling well. So it could be hard to determine.
So another good question: which hospitals in the area have the hyperbaric chamber?
So I think it's just UAB right now, and there's a very specific indications for actually getting the therapy. But I believe so. There's a whole consortium of hyperbaric chambers in the area, and I can't remember the website, but there's a website you can go, and there's actually a team that coordinates that you can call, and they will tell you which one's available, almost like a TCC setup, but it's for hyperbaric chambers. They can tell you which one you're closest to, which one's available. But I believe UAB is the only one that's.
Or
that's right. I think that's what it is, right?
And I think Princeton may have one. I know they used to.
Okay.
They still do.
I don't know.
Yeah.
Medical West has a wound care center.
Okay.
That's attached to the hospital.
And they have one.
Yeah. I'm not sure if they use it for that purpose, but it is owned by the hospital.
Yeah. The problem is a lot of these wound care places you can dive, but you can't dive people that are on the ventilator. So if you got somebody that's super sick that's too, you may have to go somewhere else, like a Mobile or somewhere, fly them there. But just dive there without that answer. We also at UAB have a on-call hyperbarics doc. So you can call UAB or you can call TCC. They can call UAB, get the on-call hyperbarics doc, and get that information. So that's 24/7 covered.
So we got somebody online saying that Princeton does in fact have a hyperbaric chamber. It says Chuck Banks is over that.
Okay.
Sweet.
So good information. Thank you for sharing that.
Yeah.
Does anybody have any other questions
all I had.
on toxicology, 12 leads, any other appropriate subject within reason? Questions, comments? All complaints should be forwarded to Chris Horn as per normal. Thank y'all so much. Thanks, Docs, Dr. Ferguson, Dr. Payne. We
Thank
really
you.
appreciate it. Very valuable.
Next time, Dr. Peterson.
So we'll have Dr. Peterson and Dr. Evans next time in 2 weeks for the next installment of Alabama EMS Challenge. So remember to please send an email to alabamaemschallenge@gmail.com. You'll receive an automated reply. There'll be a link to an attendance form. Please fill out and submit the attendance form, and that's the way you'll get your certificate. I'll probably send certificates out early next week. I've been giving people a couple of days to remember to get that done. If you have any problems with that, you can contact me at Centerpoint Fire. My email address is wward@centerpointfire.com. Thanks, everybody.